Like, let me be clear. In medical school, I maybe had 1 hour. Go to your doctor and say, how much menopause training did you have? And in my 4-year OB-GYN curriculum, I think I maybe had 6 hours. No clinics, no focused care, no nuances, very, very basic. And most of it was centered around hot flashes.
No wonder we get brushed off. It seems like every room I'm in these days, we are having conversations about our bodies and how we just don't feel like ourselves anymore. But then we get gaslit on the other side of it, and we're told you're lazy or don't blame it on your hormones. Hey everybody, welcome to the Paula Faris Show. I am your host, Paula. We're doing a month-long series on menopause and why we just don't feel like ourselves anymore. Already, I'm hearing from so many of you. Nancy says, thank you so much for doing this series. I'm 49 and out of my mind with these crazy symptoms. Thanks for talking about it. I just don't feel like myself. It's so weird. And then Lisa says, this podcast was perfect timing. I came across it as I walked out of the doctor's office after getting a full hormone blood test. It's been over a year trying to figure out what's going on with me. I had to insist. Now I just have to figure out the next step. Well, Lisa, we've got good news because we have next steps for you. And then this from Holly, who says, thank you so much for this discussion. It's so encouraging to hear that other women are experiencing the same things I am. So last week, we kicked off the series with my friends Kim and Patrice, who so courageously shared their stories and experiences about what's going on in their lives. And this week and next, we have the menopause doctor, Dr. Mary Claire Haver, who wrote the #1 New York Times bestselling book called The New Menopause. And she is going to dive in. We're going to answer all your questions. But in today's episode, what she's going to do is really explain what's going on with our bodies and why we just don't feel like ourselves anymore. She's going to tell us what the average age is for menopause and when the symptoms can start. And she discusses that landmark study that scared us all away from estrogen about 2 decades ago. But what she's really going to uncover is why we get dismissed by doctors and the shocking reasons why they're so dismissive of us and dismissive of our symptoms. And make sure you stick around till after the conversation for my pinpoint, my key takeaway. And you're also going to find out how you can win a copy of Dr. Mary Claire Haver's book, The New Menopause. Without further ado, here is the menopause doctor answering your questions, telling us why we get dismissed, the one and only Dr. Mary Claire Haver. Mary Claire, where have you been all of my life? Or should I say, where have you been the last 10 years when I have needed you so much? I am I could cry tears of joy and relief talking to you right now.
Aw. Well, for a long time, I was really busy delivering babies and doing pap smears, which is great work. But in the last, pretty much since 2018, my attention has been focused on menopause care. And in 2021, and, education around that and trying to dispel some of the myths of the old menopause and bring women into the forefront of Menopause 2.0 and also advocate for our governing bodies and professional organizations to come up to speed with the rest of us.
Thank you just from the bottom of my heart and for the however million women that are going through it, might not know they're going through it, have gone through it. Thank you.
Billions.
It is billions. And it's crazy how little research is done in this area, which we'll talk about, how it's often reduced to as like whiny women syndrome. And our symptoms are brushed off. So a little bit about me, I don't really know. I didn't know a ton about it because my mom never talked about it. Right. So we knew that my mom got real moody in her 50s and 60s and we laughed at her, but like, that was it. She didn't really talk about it. And so here I am, late 40s. Mary Claire, and I have been experiencing symptoms. I've been having night sweats since I was 38 years old. Okay. So that might be a little earlier than normal, but I've been suffering for 10 years and doctors have told me, oh, you still have your period. You're not in menopause. You're fine. They've run tests. Yeah. You're fine. I don't feel fine. I at times want to punch somebody in the face, right? So like I have so many symptoms, hair loss, weight gain, random chin hairs, like hair showing up in places that it shouldn't, like joint pain. You have in your book, which by the way, I love it. Everyone should read this book. You call it the Bible of female midlife wellness. You have a menopause symptom scoring sheet and anything over 15 indicates an estrogen deficiency. I'm at 31. So here you go. Let's jump in. So,
yeah,
Mary Claire, tell us when it starts. We know that the average age is 51 for menopause, but when can it actually start in this perimenopausal phase?
Sure. So like you said, our average age of menopause. Now, menopause is medically defined as one day in your life. Okay. So it is exactly 1 year after the final menstrual period. Okay. I don't love that definition of how we clinically define menopause, because what if you have an IUD that contains progesterone? What if you've had a hysterectomy? What if you've had an ablation? What if you don't bleed? What if you have PCOS? So that's one of the hugest problems is menopause represents the end of the function of your ovaries. Clinically. Okay. The end of estradiol production from your ovaries because you have run out of eggs. That is it. Using symptoms, the symptom of a period to define that is really problematic for those of us who don't have regular periods, or don't have periods at all. And so, but the average age of that happening, that definition is 51. Normal is still 45 to 55. So 95% of women under the normal curve will go through transition into full menopause by, between 45 and 55. Now, perimenopause is the transition period between a normal, predictable reproductive cycle to full menopause. That process can take 7 to 10 years. So do the math. So you're saying, oh, I was a little bit young. And I was like, no, you're not. It is completely reasonable for a woman to begin having symptoms associated with her menopause transition between 35 and 45.
Okay. So I'm normal. Well, I don't feel normal though, but my symptoms are normal.
Let's talk about perimenopause, because when you look at how much clinical education I received about perimenopause, there was nothing. Zero.
I didn't even know there was a term for it until a couple of years ago.
And a lot of clinicians don't know that either. They're because they're using that 1 year without a period, 1 year without a period, we will not intervene until she's 1 year without a period.
Yes.
We're missing a huge opportunity to improve the quality of life of women and her health span if we can start recognizing these things and intervene. So what is perimenopause? Okay, so in a healthy woman who has a normal reproductive cycle, she has a very EKG-like ebb and flow predictable each month of her hormones, right? So how does this happen? So the brain has the hypothalamus and the pituitary and a whole lot of other stuff. But as far as our sex hormones, just think hypothalamus and pituitary. So the hypothalamus is the control center in the brain, and it is constantly seeking estrogen levels, in the blood. So just imagine a monitor, in your bloodstream from the hypothalamus that's like, do we have enough estrogen? Do we have enough estrogen? When estrogen levels decline, as they do in a normal cycle, right? Ebb and flow, it sends a signal to the pituitary gland saying, tell the ovaries it's time to start the ovulation process. Okay. So the pituitary creates these little stimulating hormones called LH and FSH, luteinizing hormone and follicular stimulating hormone, that start talking to the follicular cells around each egg saying, hey, it's time to ovulate. And those cells start creating estradiol and some testosterone. Okay. So we have this rise of estradiol. And then in our mid-cycle, the cyst, it forms a cyst of fluid around that egg. The cyst pops, the egg comes out, it's picked up by the fallopian tube, and it's got little sweepers that sweep that egg into the uterus. And if there's sperm there and she gets pregnant, we have a baby. Okay. No sperm, no baby. Right. So, or it just, ovulation, or it was not a healthy egg and the process didn't go. Got it. Or not a healthy sperm. That's basically it. And in normal reproductive cycles before perimenopause, this is very, very predictable. On day 14, this is going to happen. On day 27, this is going to happen. On day 2, this is going to happen. And you can just predict it each month. Now, in perimenopause, remember, we're born with all of our eggs. We have 1 to 2 million eggs.
Which is mind blowing when you think of
men make they make their egg equivalents. We call the equivalents germ cells in both sexes. Men make their stuff fresh every day. Every day. It's just a factory. Keep going. By the time we're 30, we're down to 10% of our egg supply, 120,000 eggs plus or minus.
Which is crazy. I had all my babies in my 30s, which is
yeah, me too. And I was like, wow, that was amazing. So by the time we're 40, we're down to about 3% of the egg supply. So we're losing the amount and the quality. Okay. So at perimenopause, we reach this critical threshold of egg number and quality where those usual signals coming from the brain stop working as well. in that perimenopause zone, we end up in chaos, a hormonal zone of chaos. We lose the predictability and we have much higher bursts of estrogen and much lower dips in estrogen. And progesterone never quite gets to where it used to be in premenopausal years. So that's where that estrogen dominance term comes from. I don't love that term, but you end up with this delayed ovulation and really weird ebbs and flows of those hormone levels. So it's a very, very chaotic zone until the whole thing declines and bottoms out in your full menopause.
But we're losing estrogen, right? Isn't and that
so the overall estrogen levels are declining over time. But it is not like a nice linear. You end up in this roller coaster on the way.
So fun, right? This is going to be one of my questions to God. Why mosquitoes and why menopause, right? And why so long? I want to get into how we treat it. In hormone replacement therapy, you have a different term for it. But first, a couple of other questions. Like, is there a test? Because, and one thing I do love about your book, you have a scoring sheet and you have a whole toolkit that's like 100 pages long. What you can look up the symptoms because there are myriad of symptoms. There's probably hundreds of symptoms that could be related to it. So
every organ system in our body has sex hormones. And when we start jacking with the levels and taking them away, every organ system can be affected. And that, what I went through is going to be different than what you went through. That's where genetics and environment come into play. So clinicians love a checklist. You got, fever, headache, cough. That's a virus, and so we say if it walks like a duck and talks like a duck, it's a duck. And so there's no duck for perimenopause that's easily identifiable and looks a lot like hypothyroidism or PCOS or, there's a lot of overlap with a lot of medical conditions. And here's the crazy thing. In the metaverse, in Menopause 2.0 and my friend group where we're constantly sending articles back and forth, we're thinking that there's probably a very large percentage of women who are diagnosed with things like fibromyalgia. That's probably actually perimenopause.
Really? Okay, because I've been treated for
interstitial cystitis is probably perimenopause.
Oh my gosh. So yes, there's a lot of symptoms, a lot of misdiagnosis when we're actually in perimenopause. You say that there's not a test really, and that's what's tough. So how do you know you're in it? Is there a test?
Remember, hormone test, not helpful. There is a hormonal zone of chaos. So a one-time blood, urine, saliva test or paying hundreds of dollars, some of my patients
they're going to say you're normal. They're saying you're normal.
I'm like, me reams of paper and most hormone tests look kind of normal.
Right.
Just depends on what day you do it because the next day it could be different. But postmenopause, we have great tests. That's easy. Postmenopause blood tests, we got it. We know how to diagnose postmenopause, right? But so how do we do it? We listen to the patient. We believe her. And maybe do blood work to rule out some of those overlapping things. Like I'm constantly checking for thyroid disease. I'm checking for autoimmune disease. I'm checking for nutritional deficiencies, inflammation markers. But most of the time those look okay. And then we're like, okay, it's your perimenopause.
Okay. So you need to find a doctor that listens to you. And there can be some blood screening when it's almost like the process of elimination. You're ruling out certain things.
Exactly.
Okay. But there is no established, you say in your book, there's no established one-time blood test that can tell your doctor where you are in the process, right? So,
right. It's kind of like, it's a puzzle. And so they can use your period, your symptoms, ruling out other things in blood work. And then it's like you kind of rule everything else out, process of elimination, and then be like, okay, it's your perimenopause. So we're not educating our clinicians about it.
So I've been having these symptoms. Like I said, I had my son at 30, my youngest at 38, and I started having severe night sweats, like to the point where I had to change my clothes and change the sheets. I've been having those for over 10 years. How do I know where I am in the process? Is the answer we just don't?
So, well, I know you're perimenopausal based on your age and your symptoms.
But where am I in the process?
Assuming you've seen Well, there's one, if you do like 5 blood tests for FSH and they're all above 25, and we know you have about 2 years but no one's doing that.
Okay, FSH.
So
follicle.
FSH is follicular stimulating hormone.
Okay.
So that rises dramatically in postmenopause and stays elevated. Because remember, the brain is always, whether you're menopausal or not, looking for estrogen, and it's forcing the pituitary to make those signals. And so when your estradiol plummets in postmenopause, then that level is going to stay elevated because the brain's constantly trying to get the ovaries to work again and they can't.
Okay. I got it. And I'm still having periods, but they're heavy. Yeah. I might skip a month.
This is classic. 90% of us will have dysfunctional uterine bleeding like you're having.
And I've read it can last decades too, like the whole process,
it depends on the type of symptoms. The best data we have, because forever menopause symptoms were defined by vasomotor symptoms, hot flashes, because you can't blame that on anything else.
Yeah, for sure.
Right?
Okay.
But most clinicians don't know the musculoskeletal syndrome, don't really understand the depression, the anxiety, the brain fog, don't really understand how the gut's affected, don't understand the skin changes. Everything gets, kind of siloed into go to the cardiologist for your palpitations, go to the dermatologist for your skin changes, go to the, and then we're not teaching clinicians to connect the dots.
One thing I really loved about your book, you're a doctor. You went to med school. I was blown away by not only the lack of research, but how it's treated in the medical community. You wrote that 20%, I believe it's 20% of OB-GYN residents, only 20% are offered menopause training, and 80% of the residents felt barely comfortable discussing or treating menopause. So it's not just a lack of funding. They're not trained. And that's why we get told
we haven't prioritized the last. In medicine, we have not prioritized the last third of a woman's life. It's like, okay, what can we do to prevent osteoporosis? Roll up the rugs. We're only going to wait until you have it before we try to intervene. There's no discussion about prevention of osteoporosis, about, the protected benefits of the natural estrogen in our bodies. It's mind-blowing to me. And I won't stand for it.
Good for you. And please keep speaking up. I was blown away when you said you would overhear other doctors say, oh, it's someone with WW, which is a whiny woman in room 4.
Woman. Yeah.
Can you just speak to us and give us a little encouragement? This isn't in our head. There's something going on, and we're going to get to the bottom of it.
There's multiple reasons why we have ended up where our value plummets as a female once we're done with reproduction. Medically, when, follow the dollars, look at how much is spent on pregnancy versus how much is spent on menopause versus how much is spent on perimenopause. Okay. So of the NIH budget, National Institutes of Health. So this is not big pharma. This is the government paying for research for us all to be healthy. It's 0.03%, less than 0.5% of the budget is spent on anything to do with menopause.
Something every woman will go through 0.03.
Right. And I'm not just talking about getting rid of hot flashes. So here's what's happening today. If we just go with the flow, accept what the medical community is offering to us, and we do our best to stay healthy, right? You have a 3 times higher risk of ending up in a nursing home than your male counterpart. We're living a little bit longer, but we live 25% of our lives in poorer health than men. It's ridiculous.
Quality.
We have frailty off the charts and dementia off the charts. Women are growing old, not able to take care of themselves. I want to be a benefactor, not a burden to my children.
Good.
And so I'm very, very focused on what I can do now, and hormones are a part of it. You can't not address the nutrition, the exercise, all the things to keep me out of a nursing home for as long as possible.
Yeah. Good for you. I was encouraged. You had posted about this historic bipartisan legislation that just passed.
So we're getting there. We're chipping away at it. So, and that's great. We're moving the ship, but it is a big ship to course correct. So we can't say, okay, we passed one law. This is big. This is all, this is the health of women, and we must prioritize it because we are not little men with breasts and uteruses, which is kind of how we've been treated medically.
So let's say I go to my doctor. I'm having some symptoms. I want to know if they're related to perimenopause. The first thing you said that you would do, you would find a doctor that listens, but then screen for certain maybe autoimmune disorders and do process of elimination. And then so you can ask for those tests, right? So if I'm going to my doctor asking, so let's process of elimination, let's rule some things out, and then do an FSH blood test? Is that
so? If you were still having periods that were regular, I would not do an FSH. It's not going to be helpful. At that point, I would say this is perimenopause.
All right.
I believe you.
Okay.
If your periods were getting really far apart, I might send one. Again, it's a very nuanced, complicated algorithm in my head. We have the green scale, which is what that little checklist, the scoring system was based off of. It's validated,
right?
But no one's using it. I didn't even know about it till I did my deep dive into what's going on with menopause. And I was like, whoa, the Australasian Menopause Society is using this. Why aren't we?
Right.
Why isn't this even talked about?
You're an OB-GYN. And they're not teaching you this stuff.
No. So
mind-boggling.
Let me be clear. And we'll talk about the WW. In medical school, I maybe had 1 hour. And you can ask any doctor. Go to your doctor and say, how much menopause training did you have? And in my 4-year OB-GYN curriculum, I think I maybe had 6 hours. No clinics, no focused care, no nuances, very, very basic. And most of it was centered around hot flashes.
No wonder we get brushed off. No wonder we go in with symptoms and we say something's wrong. And they're like, well, your levels are fine. You're not
right. We're not training our clinicians. And so it's, it would be easy to just say that a doctor's terrible and and they don't care. But literally, like, this is a systemic problem.
Yes.
Also, how we view women who age, how we're valued in society. 1 in 5 women in menopause is quitting their job because they can't think anymore.
Mm-hmm. The brain fog.
For brain fog. And this is the time of life when we're like trying to lean into our jobs. We've raised the kids. We've done the things, we finally have the time to take off in our careers. We have all this experience, all this wisdom, all this knowledge, and we can't function at work.
It's insane. Okay. So how do we treat it? And I'm not just saying, look at me, but I was scared of hormone replacement therapy. You call it menopause hormone therapy because of that landmark study years ago that has since been debunked, but it scared everybody away from hormone therapy. So
the announcement of the initial findings of the Women's Health Initiative came out in 2002. And that was my last year of training. I remember that like a bomb going off. So the headlines read, estrogen causes breast cancer, and you'll basically die if you take estrogen. Most of that has been completely walked back. Women on estrogen only. So if you're choosing menopause hormone therapy and you don't have a uterus or you have a progestin containing IUD, you can opt out of a oral progesterone or systemic progesterone because that's really was placed there to protect the lining of the uterus from unopposed estrogen and developing endometrial cancer. And so, but the women who had hysterectomies in the study and were on estrogen only had a 30% decreased risk of breast
cancer. We didn't hear about that.
We didn't hear about that. You didn't hear about everybody had a decreased risk of colon cancer. Everybody had a decreased risk of osteoporosis. Everybody had, we never heard about that. And it was the number one medical news story of 2002. It was on there was no internet back then, but every magazine, every newspaper cover, it was covered heavily in the TV media. And they're just reporting what these people are saying. It's not the reporter's fault. So, but I remember Nancy Snyderman saying, I would never give it to my mother. Women should not be taking this, and she was just going off of what was
the
said.
report.
So, and that was 2024? That was 22 years ago. And no one had big announcements. So they announced it at the Watergate Hotel. They held a press conference before the study was even published. It didn't get published until 2003. So no one was allowed to look at the data or, reevaluate it. And here are these investigators patting themselves on the back. We're saving women. This has so been walked back. Estrogen is incredibly protective. And it is the time away from estrogen, of any source, from natural or given it to exogenously, that leads to disease, accelerating disease. We're still going to die, even with HRT.
Yeah.
But we are not much less likely to have these protracted courses of decline. Men typically have a heart attack and die.
Right.
With living their best life, with a very short period of advanced decline requiring all this help. Now, this is not all men. Okay. I don't want anyone to feel bad if their dad was in a nursing home for a long time, but women are expected right now in 2024 to have dementia at 3 times higher rate than men, 4 times higher rate than men, and have 50% of women will have an osteoporotic fracture versus 25% of men. Why are we not talking about this? Just as many women die after a hip fracture than die from breast cancer.
Okay, so this is typically, hormone therapy is the most popular way to treat the lack of estrogen, which is happening in our body. And again, what I learned, it's the only, okay, so there you go. So, but a loss of estrogen can cause heart disease, stroke, Alzheimer's, type 2 diabetes.
Yeah. So it turns out estrogen is very anti-inflammatory and very, very protective of the brain.
Okay.
And in the, the lining of those little, vessels around the heart, the coronary arteries, the intima of, is estrogen is like very, very protective against forming plaques. And when we take the estrogen away, we see an acceleration of that process. All the risk factors for cardiovascular disease go up. Your cholesterol goes up. Your blood pressure tends to go up. and your insulin resistance goes up just from the lack of estrogen. And that's what we're not talking about, what we're not educating women about, so they can make an informed choice for their own healthcare. We're just like, estrogen is bad. It's going to kill you and give you a heart attack. We'll only give it to you if nothing else works and you're suffering from hot flashes. It's ridiculous.
So the thing that they're keeping away from us is actually the thing that's going to make us better. So tell us how we treat it. You're saying estrogen,
so,
right?
You know, when I talk about menopause care, when my patients come in, wherever they are in their journey, and perimenopause is a whole different animal. So she's postmenopausal and like, should I be taking hormone therapy? So certainly if she has symptoms, there's no debate. If she's having severe vasomotor symptoms, severe brain fog, severe musculoskeletal symptoms, the best thing is estradiol therapy. And so we're going to give it to her. But what if she's not symptomatic at all? About 15% of women, 10% of women will kind of skate through it without any severity. They just stop having periods. Then I begin the conversation, even though, God bless them, the U.S. Preventative Health Task Force has not, they still use the data from 2002. It's the most frustrating thing to me. And to the menopause, so that, you know, they won't get up to speed. They're still trying, they're gatekeeping estrogen for women, which is, I think, ridiculous. I don't think every woman is going to choose it, or, you know, but I think she deserves the informed conversation. So what I tell my patients is, look, the American Heart Association is clear. Women who are given estrogen, there's a window of opportunity within the first 10 years of their menopause, will have decreased risk of cardiovascular disease 50% per year. Will have a decreased all-cause mortality, will have decreased death from cardiovascular disease. The data is clear, and that does come from the WHI. There's a window of opportunity. But once those disease processes become severe, estrogen's not going to be helpful for her. So we want to limit the time that she has away from estrogen to as small as possible, at least for cardiovascular disease and for Alzheimer's. So estrogen is protective against Alzheimer's if you begin it early.
All right. What about in that perimenopausal stage? Are we just supposed to suffer, or would you give me
if she's
or
symptomatic,
anybody?
hot flashes, night sweats, whatever, we're talking about therapy in perimenopause. I'm not waiting for her period to stop. So I don't need that. However, there's beautiful data coming out showing estrogen is more effective on perimenopausal depression and mental health changes than the SSRI.
And the SSRI, remember, not yes, which I'm on Prozac. I've been on it for years.
Yeah. And not to say you don't need your Prozac. I love having options, medication. But if you've noticed you were doing great on Prozac, then all of a sudden the symptoms are back. You're not able to manage. You need to be trying estrogen therapy adjunctive to your SSRI to see how it goes. Give it a trial. Why not give it 3 months?
I would love to. So who should tell us this? So if you're saying estrogen, which we're calling hormone therapy, sometimes it's called HRT, which is hormone
replacement therapy,
therapy, or MHT, menopause hormone therapy. So we're kind of using that interchangeably. So if hormone therapy is going to treat pretty much all of these symptoms, right? And this is just estrogen, who should be taking this? Perimenopausal women, women in menopause, and postmenopausal women?
So my daughter is a first-year medical student. Well, she's now second year. She just finished up. And
congratulations.
She thinks that, well, it's all her. You know, I just fed her and watered her and paid for everything. So
did you say watered her?
Feed and water and put up with a surly teenager. But she really did this on her own, and I cannot take credit. Catherine thinks that menopause should be optional. And that why would she ever allow the chaos to affect her brain, her ability to function, you know, in perimenopause? And that she's going to be, of course, she's a little radicalized because mom, but
I got you.
But she's like, this is ridiculous. Like, why do we let women suffer? Why do we have to have a level of severity before we intervene? You know, why would I not be functioning at my highest capacity throughout all of my life? And she thinks menopause should be an option.
Hey, could I start seeing her? Is she going to be an OB-GYN? I don't even know.
She does not want to do it. She doesn't want to suffer through an OB-GYN residency to take care of women. You know, and again, I think she's right. Why should women, all of the health of women, be dumped in the lap of the poor, busy, procedure-focused OB-GYN? You know, like we have a lot to do. Delivering babies, surgeries, pap smears, screening. Like this should be mandatory for all medical students. You know, how does disease affect women versus how does disease affect men? It's different. And we're not focusing on that. That's not where the research dollars are going. And that's what needs to happen. And then every single specialty that touches a female needs to say, how is the aging female different than the aging male?
Okay. And pardon me if I repeat things or just say, am I hearing you correctly?
Clarification.
Because I just want to make sure that I'm getting it correctly and that everyone listening or watching gets it correctly. So the hormone replacement therapy, estrogen or MHT, before, during, and after. So all three phases.
And after. Yeah. So menopause is one day, you know?
Yep. That's right.
So peri, absolutely. If she's symptomatic and wants it, I'm going. I'm asking her.
Yes.
We're discussing it immediately. And post for sure. So,
Going back to the bad rap that hormone therapy has had. So we brought up this landmark study that really scared, and this is something I hear to this day. And it's honestly one of the reasons I haven't even thought about hormone therapy. I didn't even really know that there was a landmark study or what was said. All I have heard is that hormone therapy is bad and it can cause an increased risk of cancer. That's all I've heard. I didn't know there was a study.
Is as resilient as a menopausal chin hair. I'm like, you know,
I know. But I want you to clarify. So hormone therapy gets a bad rap because of a landmark study that scared women away from hormone treatment 20 years ago. And the reaction was overblown.
The findings were misrepresented and the risks of estrogen are grossly overemphasized. Remember, every medication we take has risks and benefits. I'm not saying that estrogen doesn't have risks. And the benefits were grossly underemphasized.
Okay.
And it's holding true today. The Lancet article that just came out, I can tell you 50% of the menopause stuff coming out is still overemphasizing the risks and underemphasizing the benefits. And that's where the menopause is saying no. And using our voices, our power, our being authors to say, we're not going to stand for this and we're going to fight for the rights of women so that they can make an informed choice for themselves. But it's a big ship to course correct. You're right.
It is. And I thought it was really fascinating too, this decrease in estrogen during this time. And the decrease in estrogen is actually, it can lead to the number one killer of women, which is heart disease.
Yeah.
Your book is amazing, by the way. I really feel like
it's the path. You still might get heart disease, but we can slow it down.
Yes. Okay. This has been awesome. I need to find the right doctor because I actually left my first OB-GYN because I'm like, I'm not feeling great. I listed all these symptoms and she literally looked at me and said, you're still getting a period, right? And I said,
that's how she was trained. And that was me for a long time, Paula. I was her, well-meaning, really good, great at babies, great at everything else. But there was a huge gap in my menopause education. And I had to go outside of what the American Board of OB-GYN put in front of me every year for recertification, and really dig into this on my own. And thank God I had a horrible menopause, transition, because I don't know if I'd be here today as part of this kind of revolution if I would have had an easy course.
Right. So in some ways, it's not that we have to let doctors off the hook, but we have to understand that they've been given no training and there's been no research.
And there's almost no time to be able to dig into the research,
No, you guys are buried in paperwork and you're seeing 40 patients a day. So if you want to learn about it, it's on your own volition. It's like your own spare time and free time.
When my kids were little and I was trying to mom and do all the things, I had no time, to go outside of what the burden I already had. So it wasn't until things kind of got easier for me as far as involvement with the kids, once they could drive and you're not there yet, but
No, I have a 16-year-old and a 14-year-old and a 10-year-old. So my daughter's driving right now. I don't know where she is. She's driving.
It's like the best thing that ever happens to a mom.
It's great. It's like equal parts terror and relief. I took away her driving privileges for a couple of days and it was terrible. She's like,
right, you're punishing yourself.
I know. I was like, this is dumb. I got to figure out another consequence besides taking away her driving privileges.
Take away her phone. Then she still needs that for school and everything else.
Yes. And I want to track her if she's driving. So, you know what blew my mind about that conversation? It is time for my takeaways, my pinpoint. It's this. Only 20% of OB-GYNs, we're not talking about the whole medical community. We're talking about OB-GYNs. Only 20% are even offered menopause training in med school. And 80% of medical residents said they felt barely comfortable to talk about it. There's no research, there's no funding. Right now, we know that that's all changing, but no wonder the medical community doesn't know what they don't know. No wonder that we get dismissed as whiny women or WWs. No wonder they tell us you're fine when we don't feel like we're fine. Okay, a couple of my other key takeaways. We haven't prioritized the last third of a woman's life. We really haven't. Again, the tides are changing. And then the hormone therapy. All I knew about hormone therapy and estrogen was that it was from the devil. Like it would cause cancer. I didn't know really why, but it all dates back to this landmark study from 2 decades ago that, as Dr. Mary Claire Haver said, has been pretty much walked back, but we just haven't heard that it's been walked back. We haven't heard what's on the other side of it. So it's so important that we educate ourselves, and it's so important that we continue to support platforms like Dr. Haver's, who is getting the word out there that estrogen is actually going to save us and save our lives and make us feel so much better. We're depriving ourselves of the one thing that's probably going to give us some incredible relief. I'm going to take you on my own personal journey throughout this series as well. I started hormone replacement therapy, which we refer to as HRT or MHT throughout this series. And I'm going to take you along my journey, tell you how I'm feeling. But so far, you guys, it's made a huge difference in my life. And I wish I would have known this a long time ago. In next week's episode with Dr. Haver, we are answering all your questions. And I mean, Jill, Janice, Sarah, Tara, Cheryl, Kim, Sue Alice, Amy Elizabeth, Holly, Janice, Salmo, Kim, Crystal, Tara, Gina, Kristen, the list goes on. I mean, when I say we're answering your questions, we are answering your questions that you submitted. And if you want to win a copy of Dr. Haver's #1 New York Times bestselling book, The New Menopause, make sure that you are subscribed to my personal newsletter at paulafarisofficial.com. I have a link to my personal newsletter in the show notes, and you'll find out how 5 of you will win a copy. Again, next week, we are back to answer all your Q&A. We do not have to suffer in silence. We are going to get better, and we are going to feel like ourselves again. I promise. You know why? Because we're talking about it. I'll see you next week. I know you guys thought you were done with me, but not quite yet. I have one more thing to tell you about. If you're watching on YouTube or you're listening on your favorite podcast platform, don't forget to subscribe to the show. I don't want you to miss a single beat or a single conversation. And remember, my DMs are always open. Tell me what you want to talk about.